right, good morning, everyone, and thank you for joining us. I see we have a good quorum, so I think we're just going to begin. So, again, thank you for coming and joining us, and welcome to our conversation where we'll be talking about adolescent mental health in Kenya. My name is Faith Kamau, and I'll be guiding today's session. So we'll just begin quickly with some housekeeping rules that will guide us as we are going along our session, and just a few things for us to note. So first of all, I think as you've seen, we are recording, so don't worry, slides and a short brief will be shared after the presentation, just in case you've missed anything. And then because this is a webinar and we are presenting, you might not be able to ask your question as the session is going along, but we will have sessions for Q&A after the presentation. So please add your questions in the Zoom Q&A, the Zoom chat at any time. One of my colleagues, David, will be in the chat and will be interacting with you, and will give you a session where we'll be able to ask your questions, whether you want to ask them in the chat or whether you want to maybe just raise your hand later on during the Q&A session and ask your question. And you can upvote questions that you want addressed. And speaking of the chat, when you're in the chat, please let's try to keep it respectful and concise so that we can make sure that we all have a good session. I hope that is okay with everybody. So we'll just start in the next 1 minute. But now talking about more on what has brought us here today. Today we're here to talk about youth mental health, and I know by you being here, you have a vested interest in it. And specifically, it's important to talk about adolescent mental health because it is such a critical turning point. And when people are adolescents, at that point, mental well-being at that stage can affect their lifelong physical and emotional health, their learning and their social engagement. And so that's why today we'll be talking about depression and anxiety and well-being among Kenyan adolescents over the last couple of years. And our aim is pretty simple. We want to share our recent findings, discuss what they mean for young people, for schools, for families, for communities, and for policymakers, and for everybody who is here today, no matter what capacity you have joined us in. So I think we'll just begin with a few things. So we'll have a few speeches from one of our members at Shamiri, and then we'll have a presentation on the said findings, and then we'll have a panel talking about these findings that we have, and from there, we'll have sessions of Q&A in the middle so that we can all interact and it can be a productive conversation. So in the meantime, we'll just start with one of the keynote speakers. So if you'll just give me a moment and then we'll begin. Our first and our keynote speech will be given by Dr. Maureen Gasser. And she's a behavioral scientist and a clinical psychologist who has over 16 years of experience in mental health interventions and behavioral science, as well as trauma-informed research and human-centered intervention design. She holds a PhD in clinical psychology and an MA in counseling psychology, as well as a BA in communication. And she is a research manager here at Shamiri Institute. And we're so honored to have her to sort of lay the land for this conversation and set the stage for everything else that will be coming later. So I'd like to invite her to begin.
Thank you, great. So thanks, Faith, for hosting us this morning and for that wonderful introduction. I'll probably just take a few minutes to give a background of why we are here today and provide just the context of what we expect to get from this discussion. So it is an honor to be here this morning and to be talking to you. And we do not take it for granted that you have gotten the time to actually join this webinar, which is a good discussion space for mental health practitioners and researchers and the youth to come together to discuss youth mental health. So as Faith has said, my name is Maureen Gesa. I'm currently the research manager here at Shamiri and support a lot of the research interventions that we do in order to ensure that all our mental health support to the youth and specifically for the high school students are informed by research. So today, in the couple of minutes that have been given by Faith, I just wanted to put a few pointers across as we listen in to the presentation on the research findings that one of my colleagues will be providing, as we listen into the panelists, and as we get to hear your questions and respond to your questions. Just one thing that I would want us to all have in mind is how best can we reach the youth with mental health services, and how can we make those services affordable and accessible to all the youth. And that is basically where Shamiri comes in, because here at Shamiri, one of our, or actually our main mission is to ensure that youth are thriving. And how are youth thriving? First, we have to be very keen on their mental health. And so at Shamiri, what we do is we provide evidence-based mental health intervention, meaning that all our interventions are based on research and they are tried before they are implemented. And so far, with all the research we've done, it has shown that these interventions are very effective for the youth. So as Shamiri, we can only go so far in terms of reaching the youth. And what we like to do, and an example is this particular webinar, is to find a platform and a space for us to talk about our work and to listen in to what else is happening out there through the discussions and questions that come in from the participants who join our webinars. So for those of you who are joining this webinar for the first time and you're interacting with Shamiri Institute, feel welcome, and you will probably be getting more invitations to join our future discussions. So at Shamiri, we combine research and compassion, and as our service delivery team and our team of psychologists and lay providers go to the ground, they are guided by compassion to ensure that we are working first within the ethical backgrounds, but also ensuring we leave the students at a better place than we found them. So you will be hearing more about Shamiri in one of our panel discussions as you interact with that team, but also as you listen in to the presentation, which is the key research findings, we will be really happy to get questions from you, get more suggestions on what we could do better in terms of reaching the youth. And in that process, we continue to learn. So this is not a webinar for Shamiri to come and tell you what we are just doing and what you need to do. It is also a learning space for us. And as we continue the discussion, I'm happy to host you together with my colleague Faith, and looking forward to a fruitful discussion. Thank you, and back to you, Faith.
All right. Thank you so much, Dr. Maureen, for laying the land and for that wonderful speech that you've given us. I think we are all ready for the conversation to begin now. And I hope that helps to set the stage for us and to put us in the right mindset for us to be having this conversation. And so, like Dr. Maureen mentioned, we'll be having a presentation that will talk about the findings that we have on youth mental health. And it's not just Shamiri specific, because these findings are collected from young people all over Kenya. And to take us through that, we'll be having Rosine Baseke, who is an senior associate here at Shamiri, who will be talking to us a little bit more about these findings. And I think I'd like to welcome Rosine.
Good morning, everyone. Thanks, Faith, and Dr. Maureen for the introduction. And another thank you to everyone for joining this discussion. I think it's a very important discussion to be having. So in this segment, I will just focus on the findings, specifically just understanding um, depression and anxiety among young people. And so what we found in our research, why it matters, and then what can be done moving forward. Right, so we'll just get into it. The main reason why we even think about investigating adolescent mental health, so there are three things majorly. So the first is the current data that we have has a few limitations in terms of the sample size, and we also have issues of measurement. So tools that are being used to measure these kinds of things are not culturally sensitive in terms of truly understanding how symptoms are understood, interpreted in different um, environments. And then we also have the issue of stressors, so local stressors that are specific to a context. Some contexts have issues like family instability, academic pressure, which in Kenya, there's a lot of pressure that's put on high school kids in terms of being able to pass. And so all of these things have a way of affecting young people. And this is why we need to understand on a deeper level about their mental health. So the study had a few objectives. We can just move to the objective section. So the first thing, we just wanted to assess the prevalence of depression and anxiety symptoms among young people. And we also wanted to identify what are the most impactful or significant symptoms that are affecting their well-being. We also sought out to examine the tools that I was mentioning, so PHQ-8 and GT7, which are normally used to measure symptoms of or self-reported symptoms of depression and anxiety. We also had a few other objectives in terms of trying to understand what are the risk factors and protective factors that are involved when it comes to the well-being of young kids, and then also understand the variations in terms of symptoms across different school types and regions. Moving on to our design. So we conducted surveys. So this data that I'm presenting is data from 3 surveys that were collected across 3 years. So 2021, 2022, and 2023. And the data has been collected from about 27 schools across Nairobi, Kiambu, Makueni, and Machakos. And we managed to survey about 7,800 students who were aged between 12 to 20. And we worked in collaboration with AfriMem, who I believe are here today. The measures that we used, so we were looking at symptoms of depression and anxiety. We measured depression using the patient health questionnaire, which is a PHQ. We also measured anxiety using the generalized anxiety disorder screener. We looked into the general well-being, which is measured by these SWAMs. I'll get into the actual name later. And then we also measured perceived social support. We also measured perceived control, which is basically just seeing how the students feel in control of certain things in aspects of their lives. Yeah, so just getting into the participants. So like I mentioned, we had 7,865 students. The mean age was 16 years. And we had 3 surveys that we've combined here. So the first one had a sample of 1,498. Second one had the sample of 3,226. The last one had 3,141. So survey 1 was collected in 2021. Survey 2, 2022. Survey 3, 2023. Okay. Moving on to now relating to our first objective, which was to find out what are the prevalence rates and the severity of depression and anxiety symptoms among young people. So across the years, you can see there's some variations. So on average, we found that about 30% had moderate to severe symptoms of depression, which moderate to severe is having a score. So it's just having scores of 10 and above on the PHQ scale, and 25% had moderate to severe anxiety symptoms. So this is average across all the years. But now, when you zone into specific years, you can see that the prevalence rates are different. So the highest prevalence rates or the highest levels were observed in 2021. Then they drastically dropped and then slowly increased in 2023. Just to give the numbers, so 42% had depression and 38% had anxiety into 2021. And then the lowest was 25% depression and 22% anxiety. You can see the rest on the screen there. So what we are seeing is the trends are not linear. There's something that happened. We can try and figure out later. We'll get into the discussion. So in 2021, the levels were the highest. Then we see a significant drop, and then it slowly goes back up. So some of the key takeaways from these findings are there are mental health concerns clearly, and they are ongoing. We've seen a slight increase in 2023. And then there's a need for targeted mental health resources, particularly for young people. And I believe this study has really shown us that there's a need for yearly monitoring just to understand what are the emerging challenges, what are the stressors. For example, what happened in 2022 that significantly dropped the depression levels, or what happened in 2021. So these are some of the things we'd like everyone to just have in mind and think about what are the possible takeaways, explanations. So when we zoned in into the symptoms, so if you are aware of the tools, the PHQ or the GED, there are a set of questions, each focusing on a symptom. So the findings, or like the percentages I've given you, the mean is overall all the questions. So we wanted to look at the key symptoms. What are the symptoms that are coming out strongly? So for anxiety symptoms, we found that feelings of being unable to stop worrying, and then worrying about many different things. So worry is a key symptom. For depression, we found that feeling hopeless and feeling bad about oneself came out very strongly compared to the other symptoms. So these are some of the things want to be able to look at rather than looking at the overall scale. Zone in on the symptoms and understand, okay, in this region, in this population, there's a clear issue when it comes to feeling of hopelessness, feeling bad about oneself. And what that tells us is we need to have treatment plans or interventions that are more specific to the symptoms that are affecting young people rather than treating it as a whole. So we can move on to the next part, which is the protective and risk factors. So like I mentioned, we really wanted to understand what are some of the risk factors and protective factors. This helps us truly understand where we can come in terms of providing the best care for young people. So I'll start with the risks. So we found that in the sample, Form 4, so final year students being in Form 4 was a risk in terms of affecting your mental well-being. So we found Form 4s had the highest levels of depression and anxiety. We also found that being in a same gender school, particularly girls' schools, seemed to have higher symptoms compared to their peers in mixed schools. And then we also found that students who lived in single parent homes had also higher symptoms of depression and anxiety. Additionally, we also saw that poor academic perception. So we usually measure students' perception of how the academics are, like how do they feel they are doing academically. So them feeling that they are doing poorly actually was a risk factor in terms of increasing their depression and anxiety symptoms. Now moving on to the protective factor. So what made students have less or lower symptoms of depression and anxiety? So we found that adolescents who felt more supported. So remember, we had measured perceived social support. So on this one, having a good network of support and family and friend support it improved or acted as a protective factor for these young people. And also, we had teens who believed that they had control over their lives. So, levels of confidence that also acted as a protective factor when you looked at symptoms of depression and anxiety. Now, we can examine the variations across the school types. So, you'll find that, like I was mentioning, boys only schools had the lowest levels of depression and anxiety, slightly more for girls only schools, and followed by, so it was followed by mixed gender schools, and then the girls only schools had the highest levels of depression and anxiety. We can get into the numbers, but you can see them on the screen. So the trends over the years, you can just see how there were peak levels um, for girls' school, and the trends over time I think I had already explained. The insights from this specific finding is it's clear that the school environment is affecting or influencing well-being. Like we found out, girls-only schools are experiencing high levels of symptoms and of depression and anxiety, which tells us there's something that needs to be done in terms of gender-specific support and targeting those specific types of schools. So I'll just get into some of the limitations we had in the study. No study is perfect, so there were some limitations that we were able to point out. So the data that we collected, it was a sort of baseline. So it was collected at a one-time point each year. And we are aware that symptoms do not stay the same at once. So over time you find people improve up and down. So having that one time point as a data point may be a limitation to the study. We also sampled kids who were in school. And so when we look at our data, we sort of just have to limit it to kids in school. We cannot necessarily generalize it to, for example, out of school kids who may be facing unique challenges. There's also a possibility of bias as we collected these measures as self-reported. So students are usually given questionnaires and they report on how they are feeling, and that is what we use as our tools. We also had some unexpected findings in terms of vulnerable groups had lower mental health issues. And by vulnerable, I mean kids in the lower class and not lower class in terms of grade, but lower socioeconomic status. And then our analysis were based on a single time point, like I had said, so it might kind of be misleading in terms of mental health challenges, they change constantly. And it's important to point out that these studies, the findings, they show a pattern and not necessarily a causal effect. So I think we can get into now the policy implications that come with these findings. So first, we have to value student well-being to begin with, as much as academic success. Like I mentioned, there's a lot of pressure that comes with being in high school and making sure they have to pass. And so the students' well-being sometimes is overlooked. And so we need to really value well-being alongside academic success because they are both just as important. There's a need to also equip parents and caregivers to identify and respond to mental health needs. We've seen a lot of challenges with teachers and parents who they just do not know how to handle certain things that are coming into when it comes to their kids. They just don't know. And so having mental health awareness and literacy courses and interventions can really help these kids. Um, there's also some need in terms of funding. I forget the exact number, but there's a very small percentage of the national budget that's allocated to mental health each year, and that's clearly an issue. There needs to be support and resources and skills that need to be put into the communities in terms of schools, community um, development areas where they need to have support in order to support these young kids. Um, I'm just reading through some. I don't want to take too much time. We also need to build the local research capacity, and so that also involves um, giving kids the opportunity to be involved in some of these policy development. So having them contribute and giving their opinions because they are the ones who know what the issues are, involving them, building that capacity in the communities. For example, how we often involve the students we give the interventions to in focus group discussions and different needs assessments. So what they say is what we go off of. So if they have certain needs and they feel like there's something that's stressing them the most, we can't come up with something completely different. So we always have to keep involving them in what we are doing. So I think that would be it. What are the next steps in terms of looking ahead? Our research clearly suggests that there's urgent needs. Um, we need to understand fully and deeply why girls only schools are experiencing these higher levels of stress and depression and anxiety. What exactly are the underlying factors? And then we also need to assess the effectiveness of integrating some of these literacy programs and early detection mechanisms into schools and their curriculum activities, etc. We also would want or recommend to pilot and evaluate scalable mental health programs that are preventive, that target schools that are in high risk, and being able to identify which are the schools, which areas are high risk, so that we can pilot these kinds of programs that will target these schools. So I think that is it for my segment. Faith, I think I'll hand it over to you for the question section. Oh, and just before that, we want to say thank you to the Fund for Innovation in Development. They funded majority of this research, and then also our colleagues at African Institute of Brain and Mental Health. Yeah, so they really helped us, and we worked together on these studies and these findings. We thank you for their contribution.
All right. Thank you so much, Rosine, for that wonderful presentation and for all the great findings that you've shared with us. And I'm sure that really shows us why we're here to talk about youth mental health today. Because as we can see, there is a problem and there are challenges that young people are facing. And it's up to us to discuss it and figure out how can we help them and how can we help to solve some of these challenges that they're facing. And as I had promised, now we'd like to make it a discussion, and that's why we have you here today. So I would really encourage that if anyone has any questions, this is your chance. I know that we said you can put some of your questions in the chat, but first I want to begin by giving a chance to any people who would like to ask their questions directly. You can just go ahead and raise your hand if you have a question, and then yeah, we can have a discussion that way. So I'll just give people a moment if they'd like to raise their hands for questions before we move on to any questions in the chat. I think I see a hand from Debbie. Go ahead, Debbie.
Thank you so much, and I'm so glad to be part of this meeting. So for me, my question is, given that um, from the research that you've done, you've identified that most of these escalated cases are happening like in uh, high schools and among adolescents. What are the interventions that maybe as Shamiri institutes, um, what would you suggest? Like, what are the interventions that y'all are planning to implement? Because it's one thing to, to actually do the research and identify that there's a problem, but what are the solutions like now moving forward? Because even as you're talking about the prevalence being in mostly girls' high schools, like um I really related because I remembered I was in a only girls' high school, and yeah, the shege was really quite a lot. So um yeah, so what are some of the interventions that you guys might be proposing, and what can we do as either people who are in the psych field or students or just people who would want to help? Yeah.
Thanks, Debbie. Yeah, I think the research that we did, so the findings we've presented are baseline surveys. And so what happens is we just take that one time point, and that's what we've presented. What usually happens is we provide the Shamiri intervention right after we take this baseline survey. So that's one thing. We have the Shamiri intervention, which is a 4-week program that has been designed to support youth in terms of the symptoms of depression and anxiety and general well-being. And so that's one of the things we have in our toolkit. We implement every year, term 1 and term 2. We do them as just school-based after class. We have different lay providers come in, we train them, and they are able to provide the support as just peer-to-peer group. I'd call it like psychotherapy, really. So it's meant to support kids who are having these kinds of issues. We also have different types of interventions in our toolkit. So there's one we are piloting. It's called the life skills intervention. So, like I mentioned before, we did a few focus group discussions and needs assessment to try and understand what exactly are some of the stressors that are affecting or issues that are affecting young people. And in one of those surveys, we found that there were certain life skills that really were affecting them. So, social relationships, financial situations, and then we also have study skills. So, those are the three things that came out the most. And we developed an intervention that would address issues with academics, issues with their social relationships, and then trying to support them with financial skills. And when we develop such interventions, we have to test them out and make sure that they actually work. So we did a pilot, we found good results. So the intervention seemed to work in terms of reducing their levels of depression and anxiety. And so these are some of the things that we as Shamiri are working on. We know that there are high prevalence rates of depression, anxiety, and just other general well-being issues. So we are working towards building that toolkit of interventions that we can provide to these kids. But then also at the same time, there's a lot that can still be done outside of Shamiri. There's things that we would want the government to be involved in and other stakeholders, community workers, teachers. So we are constantly trying to figure out what's the best way we can address these issues. And in one of the recommendations from this study is trying to understand truly what is happening in these girls on the schools that is affecting their well-being. And so maybe in the near future, we're going to figure out, okay, let's do some more digging into these schools. Once we figure it out, we are able to come back to the drawing board and see, okay, these are some of the things, these are the underlying issues, and this is the best way to address them. I think I've seen something in the chat, the concern about the boy child. So Mercy, I'll just read your question or your comment. So my concern is about the boy child. I feel they are being left behind and they face so many challenges with no proper support systems. And then Murai also said, in my opinion, why are those numbers in girls only schools high? Okay. So there's different things we can try and come up with and just try and understand why are the girls high. It could be that there's just underreporting. Like Mercy is saying, the boy child, most boys are less likely to report how they are feeling rather than girls. So we might be finding on these surveys, we have more girls reporting truly their feelings and how they are feeling rather than the boys just, the social norms and stereotypes that boys are not supposed to speak out and say how they are feeling. And you find it's difficult to truly understand what is happening because they have been socialized to not report. Girls are more likely to say, yeah, I'm feeling sad or my friend did something bad to me and it made me feel bad. A boy, someone will be like, okay, no, just you're tough. Do it. You're okay. We might be having these numbers and they're not truly reflecting what is on the ground. And so I agree. I think we need to think about what can we do in terms of measurement. How do we truly understand what's on the ground? How do we go around this social construct that have been put into the kids' heads and how they have been taught to behave? How do we go around that to really help them? So I don't know if anyone in the Shamiri team wants to also respond to that issue. Okay. So Joanne is asking, okay, so having in mind that this was a research study, did you come across any student with severe symptoms of depression, especially suicidal ideation? And how would you go about approaching such student without compromising the research? Okay, so what usually happens is we have protocols when we're in the field. So we train first the people who are collecting the data, we train them on what they're supposed to do if they encounter any situation where a student is at risk. There's different levels of risk in this emergency protocol. There's pathways of referral. The first step would be taking the student, talking to the group leader or the fellow who would be in the field with them. If the issue seems to be beyond the fellow is going to refer this student to a supervisor. So we have clinical supervisors who are in the field ready to respond to such situations. In addition to the clinical supervisors, we also have experts who are on standby, especially every time we're in the field. So in case there's any issue that is beyond anyone, um, dealing with, they will be referred to this clinical expert who are usually psychiatrists and psychologists that will now develop a plan or tell them exactly what they need to do. So, in terms of research, what we would do is it all depends on this. If the students wants to continue with the program, we allow them. But what usually happens is if we see they're distressed, we'll pull them out discreetly and now hand them over to the clinical supervisor to handle them. As research, we're not meant to really interfere with that because we have experts on the field who are supposed to deal with them. Um, I think this will be spoken about by Veronica. We have Veronica, who is our director of service delivery. There's a very clear referral pathway in terms of risk and emergency cases that arise while we are doing the research. And yes, this has actually happened before, and we just did what I explained. Eric has said, in the next steps, I find that they are concentrating on the school participants. Will it be like we are excluding youth in the community, for example, dropouts and street kids? Yeah, so like I mentioned, it's one of the limitations of the study. We are bound by the school setup, so our programming has been focused on kids in school, in public schools, especially in schools that are more disadvantaged. So we don't go to private schools. Um, this means that what we have found is specific to youth within the school setup, so high school students in schools. And yes, it's excluding young people in the community who are street kids, dropouts. It's in my opinion at least, it's hard to reach out to these kids who are dropped out and street kids, having them in an organized setup in an unorganized way enough to give them this intervention would be quite challenging. But that's just my take on it. I'd be curious to see what you think, Eric. How would you approach these kids in terms of giving them interventions that is going to support them, or even just collecting information on how they are doing. It's quite intensive, I would think. Okay, we have Willie. Thank you for the presentation. Thank you, Willie. So based on your study, could there be a link between sleep and depression, particularly given that literature suggests females are more affected? Additionally, could future studies consider examining the role of rumination, so repetitive negative thinking, in this context? So on the first one, I'd say I'm not the best person to really respond to it. I think, oh yes, I think Dr. Victoria would be the best person to talk about this. You can go ahead, Doctor.
Thanks. Sorry for that delay. Just additional thoughts. Thanks, Rosine. Let me put on my camera. But just additional thoughts on your response in regard to the question that was posed by Eric in the audience. As Africa Institute of Mental and Brain Health, we have recently jumped into that space that has been neglected for a while. And we recently got the very first award coming from the Child Mind Institute, who I think Shamiri is partly involved in terms of the board of management. But just to speak a little bit into what we are doing, and I like what the participant has highlighted, and what Rosine you're saying, that it's a difficult space to work in, but we have already gained access into this population through actually the adults. We have been working in this space for the last now 3 years, I would say, looking at the adults themselves who are homeless and have severe mental illness, and not just severe mental illness. We are looking at various other mental health conditions. So through that entry, we have been able to also access the young people who have actually not just only gone to school, but who have dropped out and are street children. So what we are doing right now is to work together with various stakeholders in Nairobi County especially, and Makueni County, to see how best to bring these people together. We have done our initial lobbying and mobilization of the young people. And there is definitely clarity and a clear pathway into how we can work with this population. Our initial observations and results indicate to the fact that they're actually very organized families and populations, the homeless and the street families. So that's what we are doing right now, because we realize this has been a neglected population, and we will soon be presenting very interesting results, and we are looking forward to sharing them in future forums. I just wanted to add that, unless you want me to say something else, because I think our time is well spent. Thank you.
Yes, thank you for that. Yeah, I think Faith, do we have time to respond to more questions?
I think at this time we can take just maybe 2 or 3 more questions. For any questions that we will not be able to address during the sitting, just type them in the chat. We'll make sure that we will send responses via email after this webinar. So I think I have seen a hand up from Olivent a little while ago. I don't know if Olivent, you'd like to ask your question before maybe we pick just, one more from the chat.
Okay, thank you, Olivent. I just wanted to ask a question. I've supported Shamiri intervention, the last phase, that is the one that is currently ending in high schools in Kisumu. And one thing I noticed is, as much as secondary schools are mixed, then when it comes to classes, then it's not mixed secondary school. It's called a secondary school, which is mixed, but when you come to classes, boys and girls are taught differently. I don't know if you've encountered that. And that brings me to a question that when it comes to comparison, what makes the difference? Because you find that there's also a difference kind of scenario when this is played out. So I wanted to ask a question when it comes to this particular context, then what are the difference? How do you handle this particular difference? That what are the outcomes of girls in a single gender school compared to those in mixed school? Yes, it's mixed secondary school, but it's different classrooms. I don't know if you understand the context. It's
Yeah,
more
I
of a
do.
single school, but it's a mixed secondary school. That if it's leaving time, the girls leave before the boys. If it's game time, then they don't also play the same field. But it is a mixed school, but it's also not a mixed secondary school. So I don't know how that context looks. So what are the mental health outcomes for girls in single gender school, but also in a mixed secondary school? Thank you.
Yeah, I think I understand what you're saying, and we've seen this before. What we meant by mixed gender school, at least from the schools that we surveyed in these counties, it's like you're saying, however, there's still the interaction between boys and girls. So you find even during the group sessions that we give them, they are mixed. Their teachers usually what we found when we even take data from them, in as much as in a classroom there will be boys and girls, but boys, for example, on one side, girls on the other side. So that's the kind of separation we have seen. um, in as much as there's that separation, they are being taught by the same teacher. There's a lot of interaction between the boys and the girls. Whereas now the girls in single gender schools, there's no boys at all. It's all girls, all their friends are girls, all the people we sit with at lunch. So all the interactions is the same gender. And we are thinking that there's a lot of underlying issues that come with just having girls in the same space compared to having boys and girls in the same space, whether they're studying together or not, but they're just still in that same environment. And in terms of the mixed gender school, there is a way we can divide just only girls to see what their outcomes are looking like, and only boys, and then compare that with the only girls school. But that's not what I was saying. We've seen girls in mixed gender schools are doing slightly better than girls in single gender schools. I hope that makes sense and you've understood. We can do some more work in terms of understanding that context. It might be different in terms of counties. So, for example, if in Nairobi we found that mixed gender schools, they're in the same class and they go through the same things, whereas in Kisumu, for example, or in Kakamega, mixed gender schools are completely different. So those are the specific nuanced issues that we need to really look at rather than generalizing some of these things. So yeah, I think that would be it. There's one question from Willie who'd mentioned something around if there's any future studies are considering the role of rumination in this context. Um, We have had some work where we've measured rumination, but it was for a different study. And so I think repetitive negative thinking clearly has an impact, and we have not studied it yet fully. And it's possible that it's some of the things we measure for a few years and then we see what it's looking at. And from then on, try and figure out what are some of the interventions that could particularly respond to that. We tried with this program I'm talking about. It's called the mindfulness based pilot. There's research that shows it can influence or rumination positively. So it reduces how negatively students or kids think. We have not seen great results from that pilot itself. So we are thinking of trying to rethink it and redo it in a different way so that we can really have like concrete findings and evidence. On the other section of your question, I'm not able to respond, but I think we'll note it down for one of the panel discussions. I think it's a really important question between sleep and depression and how it affects genders. So yeah, Faith, I think I'm done with this section. We'll write the other questions and hopefully have some time to respond at the end.
All right, that's really wonderful, Rosine. Thank you so much for your presentation. I'm sure that all of us have found it really insightful, and even we can see from the questions that people are asking, it's been very engaging and thought-provoking. And I think we have a lot that we can learn from it, and a lot of questions that have come up from it that we can try and follow up on. So thank you so much, Rosine. And now, like Rosine said, some of these questions will be answered even further in the panel discussion that we have coming up. And so in the panel discussion, we will have a few people who have expertise in different fields, and we will be getting their thoughts and their opinions about everything that we've been talking about in terms of mental health. And as we can see here, we have Veronica Ngatia, who is a psychologist. We have Madam Mercy, who is a teacher and will be giving us the school perspective, and she's a teacher at Mili Rogi Boys School. And then we have Dr. Victoria Mutiso, who you've heard from just a few minutes ago, who is a director of research and administration at AfriMeb. And finally, we have Faith, who is a person with lived experience to sort of help us to center our conversation not only on research and expertise, but helping us to think about how is it affecting people who have lived experiences with mental health, and helping us to make sure that even as we're discussing this, we're not speaking from a point of just the data, but we're giving it a personal touch and a personal feel. And I think just to give us a little bit more information on our panelists. So Dr. Mutiso is a clinical psychologist, and she is a prominent researcher in the global mental health space. And like I mentioned, she's the director of research and administration at AfriMeb. And her work has been focusing mostly on mental health disparities in marginalized populations and developing culturally relevant interventions in Kenya. And that's why she was able to give us the context in the question that was being asked about out of school youth and children who live on the street, and how we can sort of deliver interventions to them and also get information that can help to contextualize our findings and make sure that we're not leaving anybody out. And then we also have Veronica Ngate, who is a psychologist. She is the director of service delivery here at Shamiri Institute. And in that role, she implements strategies and ensures that they are implemented to the interventions are implemented to the highest standard. So I think, like you heard Rosine mention, we do have people who are in the field who are the lay providers and the supervisors. And even like Olivant mentioned, she has worked with Shamiri. So Veronica is the one who makes sure that everything is running as it should be on the ground, and that things are moving slowly and things are moving in the correct way. And other than that role, she is a therapist, and she has been a therapist for 4 years before joining Shamiri. And she worked and continues to work with a wide range of clients who need psychosocial support. She currently holds a master's in counseling psychology and is currently pursuing her PhD in counseling psychology as well. And for teacher Mercy Okello, she is a teacher who's taught for about 11 years and currently teaches Kiswahili and CRE at Mirogi Boys. She has a passion for shaping young minds, and you can see that even by her being here and joining in this conversation. And she's committed her career to inspiring students to pursue excellence in and out of the classroom. And you can see that her work reflects a deep commitment to education, not just for the papers, but as a tool for empowerment and for transformation. And we're really lucky to have her here. And our final panelist is Faith, who is a counseling psychologist and a mental health advocate. She's also a research psychologist, and she believes that mental health is just as important as physical health and enjoys guiding individuals towards resilience. And that is why she is here today to join in this conversation and to help us to make it a bit more grounded. And we're also really lucky to have her here. So as you can see, these are our panelists. And I think just similar to having Rosina on the screen, it would be great if we can have our panelists on the screen so that we can have this conversation. I think you can see them on the side. All right, that's great. And to start us off, I know I've given everybody's introductions, but it wouldn't hurt if you wanted to just, in case there's anything I've missed and you wanted to mention it in your introduction, that's great. As everybody is introducing themselves, the first question that I'd like us to start with is, which finding from this study surprised you the most and why? And what do you think is an assumption or assumptions that you held before hearing those findings that might have changed? So again, just can you introduce yourself and tell us what finding from the study surprised you the most and why? And in case there are any assumptions that you held before this, the findings were discussed, you can also tell us about that. And I think to start us off, let's maybe begin with Veronica.
Yeah, thanks, Faith. And hello, everybody. It's wonderful to have everyone join us for this webinar. My name is Veronica, as has been introduced. And I think I don't want to add much to that introduction. I think it serves the purpose well enough. What findings surprised me? I wouldn't say I was surprised by any of the findings, but I think there is sort of like confirmation of some patterns that are already known. For example, the fact that girls-only schools could score high in terms of anxiety and depression levels. With this, I say because data is there, and I think even the questions and individuals who have responded to some of the questions that the participants did ask alluded to the same. We know culture and the way children are socialized has a great impact on how people express themselves, for example. And in our African context, we know how the boy child is raised. The fact that we as a society tend to encourage the boy child that the more quiet and collected and the more they put up a strong face, the better it is for them. The stronger they look, the more resilient they look. When it comes to mental health and mental health challenges, we know emotions play a big part in how you express yourself and how you're feeling. But we haven't encouraged our boy children to express themselves this way. In most cases, this emotional expression is interpreted negatively. And so when we collect data that concerns emotional expression, how you're feeling, how you're thinking, I think it wouldn't be far-fetched
to say that can impact. And most especially because our data collection measures are self-reported, On the contrary, the girl child is brought up, it's okay to cry, it's okay to say how you're feeling, it's okay to share, and they're encouraged to do that. And therefore, when it comes to filling out a psychological assessment test, it would therefore as well flow naturally. I'm going to say how I'm feeling. I'm very open about it. So there are things in our society that we do that really seem very harmless. But when it comes to mental health care and support, these seemingly harmless practices and cultural beliefs that we are taught when you're growing up as our children are socializing have an impact. And not unless we find a way of undoing some of these things, of which is not easy sometimes to undo, we might have results and findings such as this, and that goes a long way to impacting the advancement of mental health care and support. Because at the end of the day, like one of the participants asked, it seems we are leaving the boy child, but if we are to follow the data, then we would end up saying, oh, boys are not depressed. There is no anxiety, but it is there. We know the challenges the boy child is going through in our society, most especially. So for me, it wouldn't be what surprised me, but it is what was actually stamped based on what we are reading now. Thanks, Faith.
Thank you, Veronica, and thank you for that really insightful answer. I think now let's just move on to Dr. Victoria. So similarly, is there a finding that surprised you from the presentation? And do you think there are any assumptions that maybe you held before that are now different because of it?
Yeah, that's a great question. Two things. And I could dip deeper into certain surprises. I am a practitioner in child and adolescent mental health. And the long-held perception and what we have seen way back in a couple of other research work we have conducted and now going on into developing interventions around what we say CAMEH, child and adolescent mental health. What surprised me is the fact that the vulnerable groups and what Rosine alluded to earlier as being a risk population or a high vulnerable population. For me, it's the children or students that are orphaned, both parents. They didn't seem to have statistically significant high prevalence rates of anxiety and depression. So to me, that was quite striking because we know such a population is very vulnerable. They are the ones who are likely to have elevated rates of depression, elevated other mental health conditions, including suicide. But this didn't seem to come out in this study. And to me, that was a big surprise. We could perhaps look at maybe there are certain resilience factors that we need to study. And I'll post some studies that we have been doing and publications that we have published along the resilience space and interventions around ego resilience, where we have worked with high schoolers and parents of those students, and we have found resilience plays a major role in protecting students and indeed everybody um, against mental health symptoms and the impact, the debilitating impact that those mental health symptoms have on health, whether physical or emotional, or even for students' academic outcomes. So I think we really now need to look deeper and see how come, and perhaps it's also an issue of statistics. Can we, maybe Rosine and the rest of us, look at what is this category of students exhibiting, other than just looking at they have low levels of anxiety and depression levels, but what else? And perhaps Teacher Mercy will talk to us about what does she observe in these students, to the extent that we're not finding statistically significant mental health symptoms among those students. And then one other striking finding is really the oscillating nature of these symptoms. In 2021, there was a peak, like for everybody globally, when COVID hit, and COVID cases began to rise, and there was a high death toll all over the place. But then we see those symptoms beginning to come down in 2022. Again, what happened? We know students were at home, and that's when there was chaos in families. But we don't seem to have had those symptoms going higher than they were in 2021. In 2022, they went down, and then they began to peak again in 2023. There's a conversation about COVID crisis, post-COVID crisis. Is that what we are beginning to experience now? That there was something to do with hibernation of symptoms, and perhaps now, if we perhaps went back and looked out for those students to follow up, what would we see? I think it's a question of reaching them out if we are able to, and see if there is any crisis happening right now. So for me, those were two major surprises. Not to say, like my colleague Veronica mentioned, that for girls, it's not a surprise. And we even know, even for older women, we are able to speak about our issues in chamas. We go and have tea, socialize, and talk, as opposed to the man in the family. He bottles up because of the socialization and what the society expects of the man, and what the society expects of a woman. She can cry when she has emotional trouble, when she has a crisis, but the man is supposed to hold up. I think for me, we need a turnaround and begin to also lift the boy child up. And just to backtrack a little bit on the girls, and I'm sure Mercy is gearing up to talk about this, I hope. Girls have become quite competitive. If you agree with me, please give me a thumbs up. If you give a girl the push, she just needs to fly. I mean, this is what we are seeing, even in the workplace. If you give the girl a push, she skyrockets. And one wonders whether the boy child sits there and observes the girl flying. So, what do we need to do? You can't flap or clip the girl's wings. And in a competitive environment, you expect emotional, turmoil. You expect emotional upheavals. You expect. So the girl is quite competitive right now, and she's likely to experience emotional upsets. That's what I can say for now. So and I welcome if there are any varying observations. Thanks very much, Faith.
All right, thank you so much, Dr. Victoria. I think those are very interesting points about the nuances in the findings that we have when it comes to mental health and mental health challenges, but also the approaches that we have towards mental health. So I think I'd just like to pose the same question to you, Madam Mercy, about any findings that may have surprised you, or if there are any assumptions that you had that have been challenged or changed by the presentation. But also, I think, the conversation that we're having about the gender nuances, being a teacher in a boys' school, if you would have any thoughts that you would want to add to that conversation, I think we would really welcome them, and we'd really love to hear your views about that as well. In the meantime, I can see that Dr. Victoria is adding a few papers to the chat. So I can see one of them is talking about psychosocial factors and ego resilience, which is a callback to one of the questions that had been asked a little bit earlier, as well as adverse childhood experiences, depression, PTSD, and suicidality. And I think somebody had asked a question about suicidality and how it interplays with depression and anxiety. And I think this also gives us an opportunity to find out more about another factor that is pretty important, which is adverse childhood experiences and how they affect mental health. So I think it would be really good for everybody who is here to try and get those papers. You can give them a read at your own time, and I think they will really add not only to the information that you've gotten here today, but even in general, you can see some of the other work that is going on. In the meantime, I think as Dr. Mercy or Madam Mercy is trying to reconnect, I think I'll just redirect the conversation to Victoria and to Veronica. So, Veronica, as we mentioned earlier, you are a psychologist, and I think something that had been talked about a bit earlier was somebody asking about the interventions that we have and what people can do. And I think that's one of the key takeaways that people will have here today is we're here to find out what can we do about this. So my question to you today is what small low-cost innovations can frontline mental health providers implement right now to be able to respond to those high levels of anxiety and depression among adolescents? And if you'd like to also talk about adolescent girls, that's also fine. I hope you
Thank
got
you,
the
Faith.
question.
Yes, I did. Thank you for that. I do appreciate that question. And as you say, when all is said and done, I think we all ask ourselves, then what can we do? That is very important. When you talk about innovations, of which interventions can also be innovations that are small, that are low cost, that frontline mental health providers can implement in order to respond to some of the issues that the presentation has raised. The frontline mental health providers, just to create context a little bit, are not always necessarily specialists. And we have all the reasons to ensure that we don't only have specialists involved in mental health care support and mental health care and support. The reason why I say this is because we know that we have a gap in terms of the available trained mental health care providers. One of the reasons why mental health care and support is very expensive is because if everybody who has a mental health need sits and waits for a psychiatrist, a trained psychologist, then we might never have everybody get or access the care that they need. In this question, I'm usually challenged by a publication that was done by Professor Ndete. He talked about the scarcity fallacy, where we tend to complain of the treatment gap. And the treatment gap is the difference between the people who have the need and those who are accessing the care that they need. And he talked about how many resources that we have not bothered looking into that are available, readily available to us, that we can make use of. One of those is how many young people, able, educated young people we do have available to us that we can utilize to provide first line mental health care and support to majority of the people who might not have very elevated mental health symptoms. And such interventions are, for example, character strength based interventions. Shamiri interventions is one of those. We have many others, such as problem management plus, an intervention that is among many that were developed by the WHO in what they call the MH gap suite. These interventions are very simple. They enlist very simple psychological concepts that have great impact. They mimic normal conversations, and therefore, because they mimic normal conversation and they don't reference mental illness, then they fit into our African context, most especially, where we have a lot of stigma in terms of mental health conversations. These simple and very brief interventions can be very useful as first line care and support for majority of people. We also have other trainings that have been introduced that can help teachers, everybody within the ecosystem of young people, for example, that can be teachers, can be parents, can be peers, that can upskill their capacity to provide first line support. These trainings are very brief as well. And these trainings, for example, psychological first aid, that sort of like are designed to be used by anyone with basic training and who can be able to extend empathy to help people who are experiencing distress. The other set of skills is, for example, mental health first aid as well, that can also be useful in upskilling, whether it's the teachers, the parents, and the peers, so that many of the young people who have not yet gotten to what we would call crisis level, they can provide support, they can provide care, and they can also link those who need to have their cases escalated to mental health professionals at that level. I think when we think about character strength interventions, basic mental health trainings that can be very helpful, then we find that we are not as helpless as we might tend to think. There are still resources that are within our reach that we can get to use and help individuals who are going through mental health challenges.
All right, thank you so much, Veronica. I think it's a really interesting point that you bring up because we know that in our context in Kenya, we do have a shortage of what we would call mental health professionals, be it psychologists or psychiatrists. However, it doesn't mean that we don't have any resources or we don't have anything that can help people who need mental health interventions. And that is why a lot of the interventions, like you've said, do focus on empowering community health workers or lay providers to make sure that the problem still has a solution. I think we'll move to Dr. Victoria. So, Dr. Victoria, back to you. So I really want to hear about is what gaps in adolescent mental health research you think still need to be addressed so that we can try to better inform policy and practice in Kenya.
Right. So let me start from the outset and say that we do have a very comprehensive Kenya Health Strategic Plan currently that actually talks a lot. And I'm glad to say this because mental health has been sidelined for the longest time. But currently, the Kenya Mental Health Strategic Plan talks about mental health and actually includes CAMH strategies. But also not just the Kenya mental health, not just the mental health strategic plan, but the mental health policy is very explicit about child and adolescent mental health research and interventions, which I'm glad to have been part of when we were developing it and agitating for it to be launched. But after it was launched, it's a very beautiful policy on our shelves. It talks about youth-friendly services because we do know that youth, just talk about adolescents and majorly youth from about the age of 14 going up to maybe 30. That is a very critical age where we are also beginning to see, like in our current study, and we do know globally that age 14 is when majority, or shall we say 75% of mental health conditions begin, and then they begin to escalate as the individual grows. But we do not have youth-friendly services because the youth do not want to go to our traditional clinics, highly stigmatized clinics, with long queues and time-consuming and I would say very traditional way of providing services. So our youth want to go in to friendly spaces, friendly services, friendly spaces that speak to them in terms of how can they interact with the healthcare system. I think that's one thing that is majorly missing. Instead of going into the traditional clinic, either at the primary healthcare level or tertiary clinics or tertiary hospitals, but they want a space that speaks to their issues. That is majorly missing, youth-friendly, adolescent-friendly spaces and clinics and healthcare workers. It's unfortunate Mercy is dropping off the call, but I would have loved to hear her talk about even how the school is positioning itself in terms of supporting students who come up with mental health symptoms. Look at even this study that we conducted. I mean, high rates of anxiety and depression, high. But then the schools don't do anything about it. I would love to see a space where the students are supported, are listened to, because again, the traditional way we see in schools and especially high schools are the religious education teachers who are not necessarily trained in psychology or counseling or providing interventions for young people. Or number two, they are the elderly teachers who have been in that school for the longest time. And number three, they are the teachers who are disciplinarians. And number four, they are the teachers who look motherly. And unfortunately, that does not speak to the young people. They actually would like to see a young person speak to them. So for me, that is lacking in the schools, and a space where they are not stigmatized should they present themselves as having just a small difficulty that has not yet transitioned into a mental health problem or condition. These days, we are shying away from calling them disorders. So should a student present themselves with a difficulty or an emotional difficulty, they're not handled properly. So for me, that's something that's lacking both at school, and it's a policy and practice issue. How is the government coming in to train teachers and not just picking the teachers that look motherly, that have been in that school for long, that are the toughest teachers, that are the Christian religious education teachers, that are, those types of teachers. For me, that does not speak to the situation where our young people are at. And I think, stepping away from that also, we need funding that brings in funding for doing national surveys to give us our national statistics on where we are at in Kenya. Because we are basing our statistics on high income statistics. That's not what appertains in our local situation. So we need funding either from the local. You saw what happened to the United States policy change. It's time that we looked elsewhere. Where can we look for funding and come together as teams, as researchers, to partner and look for national statistics that speak to our situation and our context. And then also testing out the interventions that we have confirmed are working and continue to work consistently for the last couple of years. We need to find funding to scale up these interventions. They're simple, like the one we did was student-led, peer-led, and the community-led interventions. Those speak to our situations. We cannot keep on copying and pasting into our situation, because our situation, our context, our culture is different. Because the way these symptoms are even presenting, it has certain underlying nuances that we do not understand until we delve deeper into our context, our culture, and our resilience factors. For example, what appertains in the West, you'll see people say, oh, they present with PTSD symptoms. One time we were very upset, understandably so, during post-election violence. PTSD levels were very low. And people, reviewers asked us, why were the PTSD levels very low? Well, we said Africans are resilient. And that's when we began to look at what is resilience? What is this? And how do Kenyans and Africans in general present with traumatic symptoms? They may not be necessarily the ones that are in the traditional way we think PTSD symptoms present us. So we need to look at our context, our culture, and the nuances that operate in our context.
Thank you so much, Dr. Victoria. And I think you've brought up really important and interesting points about cultural relevance and what you were talking about earlier as well, with how we need to make sure that it's not just about the research, it's about how it works in the field. It's about the action. So making sure that young people have spaces that are youth friendly, because we can have all of this research that talks about how young people need interventions and that they need help. But if we're not making the spaces and we're not making sure that the help that we're giving them is culturally relevant, that it is able to be continuous, and that they're able to access it and they want to access it, then maybe we're not solving the problem. And I think very briefly, Veronica, just as a psychologist and having worked in interventions, I was wondering if you had any response to Dr. Victoria's thoughts briefly before we get some more thoughts from the people in the chat and the other participants.
Yeah, I think what Dr. Victoria is talking about is it hits home pretty much, because Africa is different. Our continent is different. And we cannot copy paste interventions without contextualizing them. As she says, post-COVID, pretty much, was different for Africa. The sheer response, how the citizenry just responded to such an adverse, event. And with that, I'm reminded of a concept of post-traumatic growth. The fact that when you expose people to a traumatic event, or what might seem as a traumatic event, they don't necessarily respond the same. There are people who will go through something that is very traumatic, that will shake some. Some will become more resilient. Some will come out more stronger and positive. I mean, cultural appropriateness, I think that is an underlying factor for researchers, for practitioners to always have at the back of our mind, despite the fact that in our trainings, whether in the colleges or universities, pretty much we read the books that are written in the West. We are trained and we are assessed pretty much, in the way that is copy-pasted. I think it is a call for everyone, whether you're a practitioner, whether you are a researcher. Just like Rosine was saying, even the psychological tests and assessments that we use, do they really give a picture of our context, of who we are, how different symptoms and signs manifest, in our African culture and context? Would depression look differently? Would it manifest differently? Would be someone who is dealing with depression in an African context, would they necessarily self-isolate? Would they be low in mood, or would they be going about their businesses because your children need to eat at the end of the day? Your children need to go to school. So, do we have individuals who are dealing with mental health challenges in our society, but we can't be able to tell because we are very much fixed on the way the Western worldview has told us this is how this mental health challenge presents? So, I think it is a challenge. It is a lot of work, but I think it is something that needs to be done. Thanks, Faith.
Thank you, Veronica. And I think on that very point and note about, yes, it's a challenge, and yes, there are all of these other external variables and factors that we have to take into account, like the Western derived tools and the fact that we have to think about the research, not just the research, but also the solution in the Kenyan context and make sure that it works for us. Yes, it's a process and it's a challenge, but it has to be done. And we have to be the ones to do it because we're the ones who understand best. And we're the ones who are living in this context, and we cannot leave the young people behind. And I think on that note, I would like to welcome questions from the audience. I know we have just 4 minutes till the end of time. I think maybe we'll just take 5 minutes extra past our cutoff to handle questions. But again, any questions we will not be able to handle within the webinar, we will send out responses via email if you leave them in the chat. So let me just check the chat. So in the meantime, if there's anybody who would like to raise their hand and would like to ask their question directly, please feel free to do so. And you can direct it to either of the panelists, or you can direct it to the whole panel and one of them will take up the question. So feel free to raise your hands if you do have a question. All right. One of the questions that we had from the chat was from Wesley, who was asking how is Shamiri partnering or seeking to partner with other players to facilitate ease of access to modern day interventions to mental health as opposed to traditional delivery forms. So, and I think I'll direct that to Veronica.
Thanks, Faith. I'm trying to find the question again. How's Shamiri partnering or seeking to partner? Yes. And the reason why this work funded by the FID, we have AfriMed mentioned everywhere. It's because we know as Shamiri, we are just a drop in the ocean. The country is large, Africa is large. We can't do this alone. And therefore, part of scaling or expanding our reach is establishing partnerships with like-minded organizations that are within the mental health, or sometimes not within the mental health, because we have worked with those without the mental health sector, but working with like-minded partners who help us to expand our reach in areas where they have worked previously. And so, for example, AfriMem has done a lot of work in counties such as Makueni and Machakos. And I think that is where they came in to help us, because they understand how the terrain looks like. If they tell you recruiting these young people of this age we can't find in this area, then you listen, because they pretty much well understand the context or the areas where they work in. So yes, we work with partners because we understand this work is too much to be done by one person alone. You can't do it alone. So we do that through what we call the train of trainers approach, where we bring in a like-minded partner, a value-aligned partner, and train them on how to execute the Shamiri intervention or any other intervention for that matter. And then we let them go ahead and do that. So through that, we've been able to reach different counties. Machakos, Makueni through AfriMep has been one of those. We have had the work expand to Nakuru County. And Olivent spoke here at some point. She is in Kisumu. There are others in Homa Bay. There are others in Migori. There are others in Kakamega. And so, yes, we seek partnerships from value-aligned partners. If you would want to work with us, please, send us an email, talk to us. We would love to hear what you're doing, what you're currently doing, and what you would want us to be able to achieve together.
All right, thank you very much, Veronica. And I think on the issue of partnerships, like you said, we can't do everything alone. And it also brings us back to what we were talking about earlier when it comes to trying to reach all the young people. So Shamiri specifically works with students who are in schools, public schools specifically at the moment. However, like you said, we have adolescents who are out of school. We have some who are living on the street. But I think it's in realizing that you as an individual, as an organization, you cannot do everything alone. And that's why you need to partner with other organizations that work in those spaces in the same way that we have worked with AfriMeb and other organizations to try and reach as many people as we can reach. I think I had seen a hand from Debbie. I'm not sure if you'd like to ask your question, or if I think I'd seen that you had left a comment in the chat a bit earlier. So Debbie, if you'd like, go ahead. Otherwise, I think we'll just go to your comment. Okay, go ahead, Debbie.
It wasn't a question. It was actually just sort of agreeing with what both Dr. Victoria and Ms. Ngatia have talked about. The need of adapting some of these solutions to our African context, and especially in Kenya, just as Ms. Ngatia was saying, the training that's happening in schools is very Western based. Like, we'll sit down and we'll learn about Freud and we'll learn about psychoanalysis, but in terms of how exactly these things apply to us in the African, context and in the Kenyan context, we don't really focus a lot on that. And so my comment on the chat was about a program that was started in Zimbabwe, where they saw there was a need to talk about issues such as depression and anxiety within their community, but they didn't really know how to go about it until they realized their community setup was one that relied heavily on conversation, either conversation with elders or peers or someone who knows a little bit more about life. And so they started a whole outreach with grandmothers and a bench. Like, so if someone was suffering from anxiety or depression or going through something specific in life, then there would be a grandmother who has been given a bit of training and equipped with some skills. And on top of now all the knowledge that they've accumulated in life, and they'll just simply have a session where they sit down and they talk. And this was repeated like 6 times, maybe 6 sessions for each person. And I thought that was such a beautiful thing, because I realized they looked at their context and they found what was working for them. And I think if we could
specific, I mean, even Kenyans, most people meet up either to eat or to share something. So if we can look at interventions that work with what we have. I think that might be greatly beneficial. Um, Even in the neighborhood I stay in, there's a lady who started an ice cream shop, and it's next to a university. And I went there one day and I realized that she's formed such a great connection with the students, and simply because they come to buy ice cream. And she actually checks up on each of the people that come to buy ice cream, and she asks them like, how comes I've not seen you for a minute? What's going on in your life? So I think it's very lovely to see that we're having this conversation about moving from the Western approach and actually formulating solutions that work for us and by us. Yeah, that's all. Thank you.
Thank you so much, Debbie. I can see that Dr. Victoria has a response.
Yeah, thanks, Debbie, for raising that very important issue from the friendship bench. Actually, I know the developer of this friendship bench is a great friend of mine. But let me say, let's not get carried away by the friendship bench. That's not new. This is something we have been doing for many, many years. Actually, what is different is the bench. We have our community health workers because you don't want to introduce something new into our system. You don't want to run parallel systems. We have to be very careful about that. Otherwise, either the school or the clinical setting will reject it. We do have our own community health promoters who are doing a fantastic job. We have been working with community health promoters, and you'll be surprised how much they can do. We are able to now to measure outcomes both for mothers and children. We have been able to work with families who just go to their houses and they interact with them in terms of 5 things. One, safety, and these are children below 5 years. Safety in the house, communication, health, in terms of looking at when my child coughs or when they are cold, how do I know whether they are unwell and where do I go? And the other thing is about problem solving and communicating with the child. Time is gone when we used to spank children if they don't do the good things. But now our community health workers are able to actually speak to the mothers and say, you have time with your baby, work with them, have time with them. And now we are in our next step is including, we are calling it actually next step. We are coining a word for it, a term for it. We want to include the men, the husbands. But we had first of all been working with the mother and the child and the siblings of that baby. So we have our own context of dealing with our situations, not to overemphasize the importance and the critical role of who are now paid community health promoters by the government. We need to go into that space and make use of what is already available. How many clinics will even give implementing partners space if you're not paying for that space? But community health promoters are available to all of us. They are available to families. They are available to schools. They are available even to individuals who can walk into that space and talk to them. Our community health promoters are now trained on the problem-based interventions. They are also trained on psychological first aid, and they know the whole care pathway for the patient. If a mother walks in with having experienced intimate partner violence, they know what to do. They know the referral pathway for that mother. They know, a lot of things are happening, so that again, we also don't copy paste from Zimbabwe, and it's not going to work in our context. We have our fantastic peer-led interventions by our high schoolers who want to speak amongst themselves about their issues. They understand each other and they can talk about their difficulties. I just wanted to let us know that we are not very badly off. Let's not kill ourselves. We are doing very well. But if we continue with that space, we will be at a good place. Thank you.
Thank you both. Thank you, Dr. Victoria, and thank you, Debbie, as well, for your points. I think, yeah, it's a good mesh of learning from those who are near peers, like those in Zimbabwe, and looking at what others have done, but also making sure that when we come to our context, whatever we do is contextualized to us, and recognizing the resources that we have, and for example, like the community health workers that you're talking about, and working with what we have and strengthening it and broadening it to make sure that we continue to work within the Kenyan context. And I think in the interest of time, I know we've gone about 10 minutes over time, like I had mentioned earlier. Unfortunately, I don't think we'll be able to take any other questions, but like I said, doesn't mean that it won't be addressed. If you have a question even now, just leave it in the chat, and all questions will be responded to, and you'll get replies via email. But I'd really like to thank Dr. Victoria and Veronica for this conversation. Thank you so much for all your thoughts and your insights about not just the findings that, like we've seen, mental health does matter. Number one, we all know that, but just recognizing the challenges that young people are facing with their mental health, and now thinking about the solution. Now that we've recognized that it's a challenge, how do we come to the solution? We need to make sure that it's contextualized. We need to make sure that it's working for young people. And we also need to look inwards and see what do we have. And I think even in the chat, we even had Wesley, who mentioned he has a startup company that's working on an exciting solution. So I think recognizing that in as much as we may not have the resources that the West has when it comes to professional mental health care workers, we have resources within us and around us that we can leverage, and that we can partner together and continue to work together to see how we can make sure that the young people who need help get the help that they need, and that it's not too late. And like Dr. Victoria said, we're not too badly off. We have things that we can continue to do. And I'd also still like to thank Madam Mercy. I know she wasn't, she had a few challenges, but even thank you for still coming to the conversation. But most of all, I'd like to thank all the people who came, all our participants. Thank you so much for coming to listen to this conversation and to also take part in the conversation, because otherwise we would just be talking to an empty room. And like we have kept saying this whole time, we cannot do it alone. Yes, we may be working in this space, but it's the stakeholders, it's the people who have people that they care about, the community, healthcare workers, schools, teachers, and everybody who has come here today that can help to make a change, because nobody can do it alone. And I know we've had all the findings that we've talked about, and I know some of us would like to go through them again and to share them even with other people. And in line with that, we will be sharing a white paper after this conversation. You will get it on email as well. So what this paper talks about is our findings from all of those years when it comes to mental health and the depression and anxiety and well-being levels in our young people. It also talks about exactly what Rosine was saying in her wonderful presentation about what can we do, what are the implications of this, what are some of the policy implications of this. And even speaking about policy, we'll also be sharing a policy brief with you all after this that now goes into, now that we've recognized that there is a challenge, that we've recognized there are solutions that we can have, how do we make it into policy so that it is being supported by those at the top who have the power to enact some of these issues. So again, I'd like to thank everybody once again for coming and listening to this conversation. And yeah, like I can see Dr. Victoria is answering some of your questions in the chat. So in the same way, we'll be sharing some of our panelists' thoughts right after this. So once again, thank you so much, and thank you for even taking the time and for remaining here even past the time that we had allocated. And we hope to see you at the next webinar that we'll be hosting, talking about still mental health and young people and what have we found out, how can we help them. And similar to that, I know the Minister of Health will be having a conference later in the year. That is still another opportunity for you all to take to go and find out what is happening when it comes to mental health. And I can see there are a lot of questions about policy. So I think that would even be one of the best forums to go and attend, so that you have your policymakers there and we can ask them directly and even hear from them directly about what are we doing in terms of mental health, and how is the government and the Ministry of Health and Education, how are they supporting mental health in young people? All right, so thank you everyone, and hope to see you at the next one.